Tajjeb, mela, nistgħu nibdew. Mela, illum nibdew naqra fuq pulse sequences. Basic image interpretation. Bażikament ibbażat fuq dak li għamilna l-ġimgħa l-oħra. Right, fejjedna T1, T2, għandkom amment. So, illum sa nibnu daqsxejn issa. Interpretation tal-images based on T1 and T2 and other sequences. Mela. Mela, the learning outcomes. By the end of the session, you should be able to understand the basic concepts of MRI pulse sequences. Explain the parameters, or the main parameters in pulse sequences, huma TE and TR. TR is the time to repeat, and we're going to explain repetition of what. And TE is the time to echo. The time to echo is basically the time when you receive the MR signal. Yeah. Describe the different signal intensities of tissues on MR images. Basically, we will be focusing on the appearance of water and fat, because the body is mainly made up of water and fat, and even pathological processes would appear as either having a water content or a fat content. So that is the basic image interpretation. Doesn't mean that there aren't other interpretations, but we're focusing on the basics so far. Distinguish between basic T1 and T2 sequences based on the appearance on the MR images. Besides the parameters, TE and TR, when you look at an image, you should almost immediately be able to identify whether it is a T1 weighted image or a T2 weighted image without having to consult the TE and TR parameters. Okay? And identify basic anatomical structures on MR images based on their signal intensity. So besides water and fat, we might look at other tissues inside the body and how they appear on MRI. Mela, let us start with some issues concerning MRI. There are a great number of pulse sequences. Aħna sissa semmejna T1 and T2, and we're going to discuss these in a little bit more detail today. Imma, besides basic T1 and T2, there are thousands of other sequences. You might have different T1 sequences, different T2 sequences, a combination of both proton density sequences. So, and the issue with MRI is that different manufacturers develop their own sequences. Mela, the end result, the final image of one manufacturer and another manufacturer may be the same, but the way they design the pulse sequence would be different. And therefore, each manufacturer would have their own nomenclature, their own terminology for a particular sequence. Mela jiena nista' ngħid isma' għandi sekwenza to produce a certain type of contrast in MRI, okay? Tal-Philips jisimha X, tal-GE jisimha Y, tal-Toshiba jisimha Z. Avolja, it's the same sequence, because it is not actually the same sequence. The final result is the same, but how they achieved that result is different. Allora, sometimes ħajkun hemm daqsxejn confusion if you are accustomed to working on a Philips unit. The sequences would be one thing. Then if you start working on a GE, you know, to get the same sequence, you need to know what is the name of the Philips sequence on the GE, because you're not going to find the same sequence. Tajjeb, so hemmhekk qatt m'hemmx standardization u harmonization of pulse sequences in MRI between the manufacturers. Okay? So hemmhekk in the table you have some examples of different types of pulse sequences and the terminology used by the different manufacturers. Just as an example of what I am saying. Okay, some may be similar in names, but some may be completely different, even though the end result is the same. Mela, let's start off. What is a pulse sequence? Mela, during MR acquisition, to remind you of last week, we put the patient under the influence of a large magnetic field. And what do we do then? We send an RF pulse. And that RF pulse creates the resonance effect. That is, the protons gain energy. All right. And what happens when the RF pulse is switched off? The protons emit that energy in the form of an RF pulse. We mentioned the longitudinal and the transverse magnetization. When we send the RF pulse, the longitudinal magnetization decreases and the transverse magnetization increases. When we switch off the RF pulse, the reverse thing happens. When a longitudinal magnetization increases, or transverse magnetization decreases. So this is what we are saying here. When we send the RF pulse, longitudinal decreases, transverse increases. When we switch off the RF pulse, longitudinal increases, transverse decreases. So here we have a graphical representation of a pulse sequence. We move to the next image. A graphical representation of a pulse sequence where you are sending the RF pulse. Pointer, خلي يكونوا يستووا يروني أحيانا. Okay, so تراوا الليزر pointer فوق السلايدز انتم؟
Eva.
Mela, you have an RF pulse. When we say an RF pulse, that can be just one RF pulse or a series of RF pulses. Okay, and after a period of time, we have the acquisition, the echo. The echo is the acquisition of the signal. But most likely, a pulse sequence is not made up just of one acquisition, because one acquisition, the signal which we acquire, would not be strong enough or of good enough quality to produce an image. So what do we do? We repeat that RF pulse. So you send an RF pulse, you wait, receive the echo, but that may not be enough. So what you do? You resend the first RF pulse, the same RF pulse. You wait again, the same interval, and at the same interval, you receive the second echo, which would be the same echo, because you're repeating. But if you add the first echo with the second echo, the signal is going to be stronger. So you have the RF pulse or series of pulses, the echo, and then you repeat again. And you can repeat as much as you like. The more you repeat, the more is the signal strength. The strength is more strong. I
think the number of acquisitions.
Yes, the number of acquisitions or number of excitations. طيب ملا عندك الRF pulse, in between عندك echo. Yet one acquisition is not enough, you're going to repeat the same thing. You send the RF pulse again, you wait, you receive the echo, and you continue. And you can send as many RF pulses as much as you like. Right? Obviously. Mela. The time from the first RF pulse to when you achieve or acquire the echo, the signal, that time is the time to echo. TE, time to echo. The time from when you send the first RF pulse until you repeat the same RF pulse is the TR, the time to repeat. Easily to remember. TE, time to echo, TR, time to repeat. Obviously, the TE is always shorter than the TR because it needs to be within the TR. It cannot be beyond the TR. Yeah. Mela, when more than one RF pulse is used in succession, ġifiri jena qed nibgħat RF pulse or a cluster of RF pulses, issa niġu għalija. Let's say one RF pulse. You receive the echo and you're going to repeat again. Mela, each time you repeat, you have a pulse sequence. Għax għandek sekwenza ta' pulses. You're not relying just on one RF pulse. Okay? So different pulses are sent at different time intervals. Mela, that is why we have many different pulse sequences. Għax jekk inti sa tvarja meta qed ngħidu qed nibagħtu l-RF pulse, you can have just one RF pulse or a cluster of RF pulses forming the RF pulse. Okay? And then you repeat. Mela, the choice of pulse sequences, again, at ngħidu lill manufacturers, they develop these pulse sequences, different time intervals, even the RF pulse itself, how it is designed. They tend to change the contrast weighting of the image. Issa sa niġu għall-image weighting. Whether it's T1 weighted, mela we're going to base more. The contrast would be based on the difference in longitudinal relaxation times of the tissues, or we're going to base it in the difference between the transverse magnetization time of the tissues. All right? So this determines the kind of signal in the image, hence the image contrast. So image contrast would be determined based on the weighting of these pulse sequences. Hawnhekk se nerġgħu nirrepetu mela għandek the pulse sequence or a cluster of pulses, not necessarily one. Okay? The time to repeat, the same cluster, it's the same cluster, not a different cluster. Okay? Ma jistax ikollok a cluster u mbagħad in the TR sa jkollok a different cluster. It's going to be the same because you want to receive the same echo at the same time interval and you want to build on the same signal, not a different signal. All right? So TR, time to repeat, TE, time to echo, from where we get the signal. Mela, TE, time to echo, TR, time to repeat, NSA is the number of signal averages. Mela, kemm il-darba ħanieħu l-istess signal, and I'm going to average it. Okay? Or number of excitations. SNR is the signal to noise ratio. U sa nitkellmu daqsxejn iktar fid-dettal regarding SNR, the signal to noise ratio, but as the name implies, it's the ratio between the signal and the surrounding noise. The higher the signal in relation to the noise, the better is the signal. Because if you have the signal, which is almost the same as the noise, you won't be able to distinguish the signal coming from tissues from the surrounding noise. And you won't have enough detail on the image. Mela, this is the same diagram. All right, għandek l-RF pulse. You have the gradients, which are changing slice selection, frequency, and phase encoding. This semmejna d-darba l-oħra. That is for the localization of the signal. But at the end, you're receiving a signal. Okay, you're receiving the signal after TE, and then after a time TR, you're repeating the same thing. Mela. Bdejt nitkellem, I was talking about weighting, contrast weighting. All right? And we said that tissues vary in their relaxation times, either T1 relaxation times and T2 relaxation times. And remember what I said last time, that T1 and T2 relaxation times are two independent processes. They have nothing to do with each other, okay? Imma, do you remember the T1 curve? The T1 curve, when we switch off the RF pulse, longitudinal magnetization, the T1 relaxation time relates to the longitudinal magnetization. T2 relates to the transverse magnetization. In this example, we're focusing on T1 relaxation time. When we switch off the RF pulse, the longitudinal relaxation, the signal, the intensity of the longitudinal magnetization is 0. When we switch off, it starts building up again. We have two tissues with a slight discrepancy or variation in their relaxation times, in their T1 relaxation time. One is longer than the other. The red line reaches its maximum before the blue line. Okay? The red line reaches maximum intensity before the blue line. Okay? So the red tissue has a shorter T1 relaxation time compared to the blue one. T1 weighting relies on the difference in tissue contrast based on the difference in their T1 relaxation time. Consider the red tissue having a short T1 relaxation time and the blue tissue having a long T1 relaxation time. With regards to those tissues, if I want to take the signal in order to have a difference in signal based on T1 relaxation time, I need to take it somewhere there, where we have the greatest difference in signal intensity between the tissues, based on T1. My TR, the time to repeat, needs to be relatively short, not large, because if I repeat when the TR is long, both tissues would have reached the same signal intensity. So I want to repeat before they reach that signal intensity. I repeat, and therefore the T is shorter. Okay, so I'm going to get the signal somewhere here, but the TR, I don't want it to be there because by the end of the sequence, both of them would have reached the same. So I still want to have that discrepancy, that variation between signal intensity. The same principle applies if I want T2. T2, when we switch off the RF pulse, the T2 magnetization, that is the transverse magnetization, is at its maximum. And then they start losing their transverse magnetization. There is a difference between them. The red has a shorter T2 than the blue one. The blue one has a longer T2 relaxation time. Okay? So the time for the echo should be somewhere in between. It's the same principle which we applied for T1. But the TR and the TE, tinsix li TE is shorter than TR. Inti the TR and TE would work in both weightings. Okay? Fit T1, if I were to use a long TR, both of them would have reached maximum. Hawnhekk, it-TE, insew it-TR at this stage. The TE If I make it too short, both of them would have maximum signal intensity if I make it too short. If I make it too long, both of them would have lost their transverse magnetization. So it would be somewhere in between, neither too short, but not too long. Mela. For T1 weighted imaging, now the parameters, the balance between TR and TE. If I want a completely T1 weighted sequence, I need to enhance the difference in T1 relaxation time, but limit the T2 changes, variations. Actually, when you're getting a signal, you're getting a signal from the protons, and the protons are experiencing both T1 changes and T2 changes. Mela, you need to be careful when you set your TE and TR. If you want a T1 weighted, to enhance the T1 difference, but then reduce the T2 difference, ħalli the contrast on the image would be weighted, għalek nejdu weighting, shifted towards T1 and not T2. Each image is going to have a combination of both. But I want the shift to be towards T1 and not T2. And if I want a T2 weighted image, then I want the shift towards T2 and not T1. Mela, with a T1 weighted image, I use a short TR. A short TR, remember if I use a long TR in T1 weighted sequences, both of them would be the same signal intensity. So a rather short TR and an even shorter TE. With a short TE, I would still have a signal coming from T2, but no difference in that signal because a short TE, they would have the same signal intensity. So any variations in signal will not be based on T2, but will be based on T1. It doesn't mean I'm not going to have a signal from the transverse magnetization, but the variation in the signal, aħna contrast we are interested in, okay? And contrast is in X-rays difference in densities, in MRI it's difference in signal intensities, the difference in the signal. So any variation in the signal will be coming from the variation in T1 and not variations in T2, because there are no variations in T2 because the TE is very short. Are you with me? Tayyeb? And the same, obviously, would apply for T2 weighting. But if I want a T2 weighted image, the TR and therefore the TE would be longer. Mela long TR and long TE, T1 would have the same signal intensity. TE, not too long, has to be within this, but not short TE. She can be a short TE. Both of them would have the same signal intensity, but a relatively long TE, but not too long, xinkella jaqbad li jaw. Jina rridu jaqbad hawn. Mela a long TE and a long TR, I would be shifting my contrast towards T2 and not T1. Tajjeb? Jekk jiena I limit both T1 and T2, how? By using a long TR and a short TE. Mela signal li għandi issa, the difference in signal, mhux the signal, the difference in signal is neither based on T1. Għax T1 long TR, both of them are the same, or no signal, għax T is very short. U l-istess hawnhekk, mela għandi signal, the changes are not based on neither T1 nor T2. So the signal would be only coming from the amount of hydrogen protons within the tissue. If I have more hydrogen protons, the signal is going to vary because you're going to have a higher signal than a tissue which has less. And that is proton density weighting, which is somewhere in between. Tajjeb? Mela għandek T1 weighting, T2 weighting, u proton density weighting. Okay? So these are different types of contrast. And for each type of contrast, you need a sequence to have the different T's and TR's to produce, jistax ikolli jiena one sequence li sattini T1 weighting and T2 weighting, waħda sattini shifting fuq T1, l-oħra ħattini shifting fuq T2. Jew, I want a proton density. Mela diġà għandi three different weightings, three different types of contrast. Tinsewx illi tissues, their characteristics, they have different relaxation times. Mela, if you are to compare the images, the MR images, basic MR images, T1, T2, and proton density, though they have different contrasts, and you can appreciate the different contrasts on the image, compared to CT. CT has only one type of contrast, which is the absorption coefficient of the tissues of the X-ray beam. It doesn't rely on anything else. So it's only the attenuation, the contrast is based on the attenuation of the X-ray beam by the tissues. But in MRI, we have contrast based on the variation in T1 of the tissues, contrast based on T2, variation of the tissues, and the number of protons within the tissue. So we already have three different types of contrast. So we can identify certain tissues much better in MRI than we can appreciate in CT. Because CT, you have one contrast delineator and that's it. So that is why then we need more than one sequence in MRI to get a complete picture of what is happening to the tissues, because definitely we need T1 and T2. Those are the basics. Proton density may give some information, because it is somewhere in between, and there are certain structures. For example, if you're doing the brain and you want to see the ventricles, the inside of the ventricles, a proton density is better than T1 and T2, because in T1 and T2, the inside of the ventricles is obscured totally by either no signal intensity in T1 or high signal intensity in T2. But the proton density would give somewhere in between. So if there is a tumor within the ventricles, it would be much more appreciated on proton density. So then you have the clinical applications of those pulse sequences, depending on what you are investigating and what you want to see. Mela, typical values. Mela, ħna tkellimna on how they appear, but typical values, meta qed ngħidu long TR, what do we mean by long TR? It's more than 2000 milliseconds. A short TR is between 250 and 700 milliseconds. Long TE, 60 milliseconds. Tinsiex jedna TE is always shorter than TR because it needs to be within the TR. So even a long TE, the longest TE is shorter than the shortest TR. A short TE between 10 to 25. And US radiographers can manipulate these parameters. All right. But you have to be careful, because if you don't know what you're doing, when we remember the characteristics of a T1, when għandek a long TR and a long TE. If you change these parameters and you move out of that range, you would easily be changing a T2 weighted sequence into a T1 weighted sequence, or vice versa, depending what changes you make. All right? So we have to be careful that you don't exceed certain ranges. Okay? Mela. The most basic types of sequences are known as spin echo sequences. Spin echo sequences where we have a 90-degree pulse. Mela tinsewx, aħna għedna the protons under the influence of the magnetic field, and they are aligned with the magnetic field. Tajjeb, you send the RF pulse, sewa, u dawk reġgħu marru in the same. Mela. A spin echo sequence is a 90-degree pulse followed by a 180-degree rephasing pulse at half the TE. Mela inti għandek l-ewwel nibdew with a 90-degree RF pulse. Jekk it-TE huwa halfway through the TE on 2, we send a 180-degree pulse. Mela inti bat RF pulse 90 degrees. Halfway through 180 degrees. All right? Mela inti you're maximizing the difference in T1 or T2, depends. Okay? Xumbat inti wara li għaddabt il-180 degree pulse. Sa tistenna, and at a particular time, you receive the echo. Right? Mela usually we say il-180 degree pulse, lew it-tieni wieħed, ġieli ma nsemmuhx. Ma aħna ngħidu li spin echo sequences usually they flip the alignment by 90 degrees. Għax in-90 degrees huwa l-iktar importanti. All right? Erħilu it's a 90 degrees followed by a 180 degree. Tajjeb? Mela, and each series is repeated every TR. Mela jiena għalhekk qedtilkom fil-bidu l-RF pulse, it could be just one RF pulse or a cluster of RF pulses. F'dal każ it's a cluster għandek a 90-degree pulse and a 180-degree pulse. Issa, tgħidli l-RF pulse, il-frequency tal-pulse ħajkun l-istess. It's the strength of the pulse illi jinbidel. Għalhekk l-alignment jaf iwadbu iktar sewa, but it's only affecting the protons which have the same frequency. Okay? Any questions so far? K-space is line filled with each repetition. Semmejtilkom l-ideja ta' K-space l-aħħar darba, which is a space which fills in frequency data, all right? U jimliħ line by line, għax hemm different methods ta' kif jintella dal-K-space, and then you can manipulate the frequencies to get an image, all right? Mela, any questions so far? Minnaħa tal-online. Hemm xi questions? Le, mela nistgħu immexxu.
Frankie?
Mela inti jista' jkollok. Għajdlu?
Jiġifieri id-degree tal-pulse dak jiddependi mill-strength. L-strength tal-RF pulse jvarja d-degree.
Yes.
Okay.
Iva. Okay?
All right.
Mela l-strength tal-RF pulse mhux il-frequency sa tkun l-istess. But the strength of the pulse tiddeflektja il-protons jew 90 degrees jew 180 degrees, depending.
Okay. Thank you. Thank you.
Mela.
Għalfin ta' 1 u 2. L-iktar importanti għal 1 hija time to repeat. Għaxan iktar kontrast u għattitu time to echo.
Iva. Pero ovvjament it's the combination of both. Għax inti trid you maximize the T1 and reduce the T2. Mela to maximize the T1, long TR. To reduce the T2, it's a long TE.
Okay.
Fit T1. Fit TR, sorry, fit T2 weighted, it's a short TR and a short TE. U proton density tagħmel long TR u short TE. Okay? Mela, u daw spin echo sequences can be both T1 and T2. Right? Ma jista' jkolli T1 spin echo jew T2 spin echo. Ġifieri sa jkolli 90 degrees followed by a 180 degrees pulse. Imma il-variation ta' TE u ta' TR ħajtuni di different weightings. Okay? Mela, qabel nitkellmu fuq inversion recovery. Inversion recovery sequences. Mela, aħna qegħdin ngħidu spin echo insew il-180 degree pulse at this stage. Mela aħna waddabna RF pulse ejjew nitkellmu fuq longitudinal magnetization. Ħajjeb, għax imbagħad it's the same principle for the transverse magnetization. Mela jiena kelli longitudinal magnetization waddabt l-RF pulse li ġi 90 degrees, allura longitudinal magnetization isni m'għandi xejn. U after a period of time, da raġa tela. U raġaħa the maximum. Mela immaġina għandi żewġ tissues which have the same characteristics. Mela għandi qed nitkellem fuq water, for example, għandi CSF, which is the natural fluid in the brain, u għandi edema in the brain, għax għandi tumur u għandi edema in it. Jew għandi multiple sclerosis. Multiple sclerosis għandek demyelination, u f'dawk l-spots fej għandek demyelination, sa jkolli localized edema. Jena, edema is still water, so I have water, both of them are water. Okay? Mela jekk jiena on a standard spin echo sequence, mela da 90 degrees, ġobu ħadd l-echo u tani l-istess echo. I cannot differentiate between normal water and abnormal water because both of them would have the same signal. Tajjeb? Imma, immaġina li qabel nibda jiena nibat 180 degree pulse. Mela 180 degree pulse daw it-tnej marru li 180 degrees. Issa, il-fatt li they are not the same, one of them is going to be slightly faster than the other. Yes? Mela at some point sa jkun hemm daqsxejn differenza bejniethom. Fil-parti fejn hemm l-iktar differenza, nibgħat spin echo sequence. Ġifieri għandi 90 degrees minn fejn ma jkunux laħqu ħadu l-maximum at some point sewwa u hawnhekk id-design tas sequences u l-manufacturers they have different designs. Mela da qed naħdmu to get a different signal between two fluids which have a slight discrepancy in their relaxation times. Tajjeb, mela bdejt b'180, mela għandhom ħafna iktar distanza issa x'jitreviljaw, mela dik il-ftit differenza bejniethom taf tagħmel diskrepanza. Jekk jienu inti qegħdin intelqu u għandna short distance, naslu tnejn fl-istess ħin. Imma jekk għandna mil, il-mil inti taf ħatgħaddi, ma se ngħidlek jiena ngħaddi lilek, le, da xejn problematika. Inti sa tgħaddini iktar. Mela immaġina, tlaqna flimkien. U hemm daqsxejn diskrepanza. At some point, se jgħidilna isma' oj, dawru d-direzzjoni, jerġgħu morru lura. U jerġgħu duru. Mela id-diskrepanza ħatikber. Qegħdin niftehmu.
Qed toħolqu inti l-kontrast.
Id-differenza ta' bejniethom qed nagħmel iktar conspicuous jiena. Sewa ġifieri kieku tellaqna short distance, konna nibqgħu it-tnejn ras imbras. Imma tawwalna d-distanza, mhux tal-li dawwalniha d-distanza, tal-li at some point arġajna jedna, uj, arġgħu morru lura. Mbagħad arġgħu morru fil-qudiem. Fimt? Allura id-diskrepanza ta' bejda u da at some point kibret. Illi mbagħad l-echo nieħdu. Mela jekk hawnhekk huwa l-finishing line. So hawnhekk huwa minn fejn tlaqna. U hawnhekk huwa l-finishing line. All right, għandi distanza. Aħna tlaqna. F'nofs triq għalinna morru lura. Mela da laħaq il-binfejġi, u dak kważi ma għandu vantaġġ issa. U għallu issa arġaw mur lura. La da huwa faster than da u issa għandu vantaġġ. Wis probabbli sa jasal fil-finishing line ħadd niktar qabel da issa. Issa, joqogħdu sejrinek, tinsiex aħna bdejna b'180 degrees, ġifieri flok kednielhom jitilqu f'dik id-direzzjoni, aħna dnilhom jitilqu f'dik id-direzzjoni. U mbagħad at some point dawwarnihom, u mbagħad arġajna dawwarnihom u ħarġa dawwar illi tista' tispiċċa b'sitwazzjoni kif ikunu iddiżinjati pulse sequences. Illi is-slow one ikun għadu minn fejn sa jitlaq. U liħor wasal. Mela jekk inti tieħu l-echo, is-signal f'dak il-punt, Da ma jkollu l-ebda signal. Għax għadu minn fejn telaq. Suppost, il-ħilu li kun mar u ġir, imma x'kien ħadna signal. Da għadu qiegħed hawn. U l-ieħor qiegħed maximum signal intensity. Allura tispiċċa għandek fil-każ ta' fluid, il-normal fluid, CSF, ma jkollux signal. U pathological fluid ħajkollu. U dak huma l-inversion recovery. Kull sekwenza li tispiċċa IR, it's an inversion recovery sequence li ġeneralment jibdew with a 180 pulse. Jibdew with a 180 pulse, followed by the spin echo li huwa 90 u l-180 li tkellimna l-ewwel. This is a basic. Ma lekketilkom li manufacturers might have different signal RF pulses hemmhekk to make this happen. Okay, with timing ta' bej l-ewwel 180 u 90 u t-tieni 180 biex jagħmlu b'tali mod li meta jieħdu signal normal fluid ikun għadu minn fejn beda, mela m'hemmx signal. U pathological fluid għandu signal. Tajjeb? Yes, jidher brighter. Okay? Mela, inversion recovery sequences are the spin echo sequences preceded by a 180-degree inverting pulse. All right? This is the basic. Nitkellmu. Mela għandek il-180 degrees followed by the spin echo. U l-spin echo tinsewx u 90 u l-180. U mbagħad tieħu the actual echo. Tajjeb? Mela di inversion time, l-inversion time huwa il-ħin mill-inversion 180 pulse sakemm jibda l-spin echo pulse. Dak huwa l-inversion time. All right? Obviously, different sequences would have different timings. Different manufacturers would design their own sequence. Għalhekk qedtilkom kulħadd jasal għalija, imma il-mod kif jaslu għalija might be different. Okay? But the end result would be subduing CSF and increasing the signal from pathological water. All right? Imma huma tinsewx. Mhux neċessarjam jista' jkun itwal l-scanning time. Fil-fatt jekk inħallu kollox l-istess l-scanning time ħajkun itwal għax inti bdejt tiskenja bl-ewwel wieħed. Allura ħajkun iktar twil, is-sekwenza sa tkun itwal. Tajjeb, imma mbagħad jista' jkun ma jkunux spin echo sequences, jistgħu jkunu fast spin echo sequences li mhux neċessarjament il-xejlu tkun 90 degrees, jista' jkun lek inqas. Jekk ikun lek inqas sa jasal iktar malajr, allura biex inaqsu l-ħin jaf l-angle, il-flip angle, għax dak li jissejja, il-flip angle, flok ikun 90 ikun inqas. Allura it's a faster sequence. Imma mbagħad il-waiting jaf ma jkunx T2 daqs is-spin echo, ikollu ftit inqas T2 jew ftit inqas T1, jiddependi. Tajjeb? Imma l-iskop tagħhom huwa li inti you subdue the signal from normal tissue and you enhance the signal from abnormal tissue. U li semmejtilkom huwa fuq water. You can do the same thing for fat. Allura għandek fat suppression sequences, fluid suppression sequences, and different types of suppressions. Għalhekk hemm ruxmata sequences u titkun tafa xiex qegħdin jintużaw.
Kontrast li jintuża għall-MRI. Dak huwa iktar water-based.
Huwa il-kontrast konna sa niddiskutuh fejn idħlu safety. Ma nista' nsemmi ftit, ma nsemmuh dak il-xejdur. Mela, one of the commonest sequences, inversion recovery sequence, hija l-flare. Forsi smajtu bih flare sequence. Flare hija fluid attenuated inversion recovery sequence. Fluid. Mela sa taħdem fuq differences in fluid. Mela għandek aħna dejjem ngħidu fluid huwa bright u da, mela da sa tagħmel diskrepanza bejn fluid u fluid. Okay? Mela qed tuża a long inversion recovery, ġifieri bejn l-ewwel 180 degree pulse u l-spin echo ħajkun naqra twil. And produces strong T2. Għaliex? Għax fit-T2, sa niddiskutu iktar il-qoddim, fluid appears bright. Għaliex it appears bright? Għax għandu a long T2 relaxation time. Mela idum ma jitlef il-transverse magnetization, allura on T2 fluid appears bright. Tajjeb? On T1 fluid appears dark għax għandu a long T1 relaxation time idum biex jilħaq. Midi jekk trid brightness, mela ħammur fuq dak fejn jidher bright, mhux fejn jidher dark. Allura fluid naħdmu fuq T2 rather than T1. So it suppresses CSF and minimizes contrast between gray and white matter. Mela this is a standard spin echo T2 weighted sequence. This is a T2 weighted sequence compared to a flare sequence. This is a flare sequence as well. Mela il-kontrast bej white to gray matter on a T2 spin echo sequence, the contrast is better. So in a flare sequence, the contrast between white and gray matter jonqos. Għandek inqas signal intensity, però fejn għandek il-pathology issa, tajjeb, and flare, even though it is a T2 weighted sequence, allura CSF suppost jidher bright, peress li għandek suppression, il-fluid m'hemmx signal ġo l-ventricles. Jekk taraw ta' fuq, il-ventricles fihom liquid u għandek a high signal intensity. Fil-flare, il-ventricles, the fluid is suppressed. And the signal is coming from pathological fluid, which is a high signal intensity. Għax kieku T1 ma jkollokx il-high signal intensity tal-patoloġija, tal-fluid. T1 fluid, nista' jagħmellek distinzjoni bejn normal u abnormal. Tajjeb? Yes. Mela, fil-kas tal-brain, il-flare tintuża for multiple sclerosis. Fil-fatt, it's one of the standard sequences tal-brain, the ANC.
So, namlu tamel brain scan normali, you would add the flare wara jew skont il-request.
Ara, a general standard brain scan, the ANC. Tajjeb, għax inti apparti multiple sclerosis, anke jekk għandek other pathologies in the brain, ħafna drabi sa jkollok edema related to it, mela it's very sensitive to detecting edema, abnormal fluid. Meta qed immorru issa bl-istess argument għandna another sequence which distinguishes between normal fat and abnormal fat. U dik hija l-stair sequence, short tau inversion recovery. Taħdem bl-istess mod, imma il-ranges ta' TE u TR ħajkunu b'tali mod li mhux se jkollhom effett fuq il-fluid, ma se jkollhom effett fuq il-fett. U l-fett li iktar li nsibuh muscles, sewa ħafna abnormalities tal-musculoskeletal system are fat-based. Mela fejn jidħol musculoskeletal imaging, l-ister tintuża ħafna.
U il-flare fil-brain breast nżawa
ħafna drabi iva. Ħafna drabi iva, ma jista' jkollok każijiet fejn jekk qed jaħseb li l-patoloġija hija fluid, ma tagħmilx ster, il-flare. Gajni ħafna drabi ster jagħmlu. Għax għandek effett content iktar milli, ma you cannot exclude li tuża flare jew ster rari tuża ster fil-brain, għax ma tantx se jkollok fatty changes in the brain. It's more fluid changes. Ma any other parts in the body, you can use either or depending on. Fil-fatt għalhekk inti jkollok different protocols u fl-MRI aħna mhux bħas CT. CT għandek CT abdomen u iva waħda u daqshekk. Protokoll isek mhux qed ngħidlek protokoll wieħed għal kollox, le. Imma jekk inti pereżempju qed tagħmel brain tiskenja CT and wieħed darba tiskenja, ma jekk inti għandek you're suspecting multiple sclerosis, is-sequences ħajkunu differenti minn protokoll ta' tumor għax ċertu sekwenzi se joħorġu dik il-patoloġija aħjar minn l-oħra. Allura jkollok different protocols, jiddependi based on the clinical indication. Mela, stair sequence short tau inversion recovery, darba l-inversion recovery time is short. Okay, dak kif biex to suppress the fat rather than suppress the water, enhances the signal from tissue having long T1 and T2. U hawnhekk għandkom different eżempju ta' l-ewwel wieħed huwa T1, T2 u ster. Okay? Le, mek liktar biex tara l-ister ħafna drabi fil-spine jekk ikollok trauma fil-bone marrow. Għax l-spine is a spongy bone u jkollok il-bone marrow. Bone marrow is fat. Jekk għandek changes in bone marrow, ħajidru. Tumors. Mela, depending on the type of pulse sequence, tissue will appear either black, white, or anything in between. Jep l-istess bħal radiografija. Mela, the aim of MRI, not just MRI, the aim of any imaging modality is to identify the normal anatomy. And classify the abnormality by morphology. Morphology hija the structure, the shape, the size, the signal intensity. All right? Ma l-anatomija. And physiologically, function. Issa, kemm MRI, kemm CT scan, the physiological information is limited. Limu imaging modality which gives us more physiological information. Nuclear medicine. Nuclear medicine, the anatomy is limited, but the function is more. All right? Mela inti qed tara l-istruttura, il-shape, il-size, whatever. U jekk għandek patoloġija u bidlitlek il-shape jew bidlitlek il-size, hemmhekk nistgħu nidentifikaw, we can identify that there is a pathology. Okay? Physiologically hemm sequences ta' għandek il-diffusion weighted, so qed nidħol fihom. There are sequences which give information about function. Ġifieri mhux imma l-iktar, the most common images are to see the anatomy and if there are any changes in the shape and structure of that anatomy, which indicates that there is a pathology. Okay? Mela, depending on the type of pulse sequence in relation to the surrounding signal, tissues may appear dark. Meta they appear dark, ngħidu hypo-intense. Hypo, lower signal intensity than the surrounding. Hyper-intense, bright than the surrounding, or of the same signal intensity. Mela iso-intense. Tajjeb? Mela, ħanerġgħu morru lura daqsxejn fuq water, fluid. Fluid has a long T1. Mela, the T1 relaxation time is long. Mela, water. Huwa il-blu jew l-aħmar. Il-blu, għax idum iktar biex jitla. Long T1. Mela, on a T1 weighted image, kiku kena nieħdu l-echo hawnhekk, water will appear hypo-intense. compared to brain tissue. Either darker compared to brain tissue. Għaliex? Għax għandu a long T1 relaxation time. Għajjeb? Għandu koll a long T2. Mela, bej il-blu u l-aħmar, which is water. This is a T2 curve, a long T2. Mela jdum biex jitlef il-transverse relaxation time, mela li mu. Huwa il-blu. So. Mela, jekk jiena nieħu signal somewhere in between, water is going to appear brighter than the surrounding tissue. Mela sa jiġi hyper intense. Bright, hyper intense. Għax għandu a long T2, idum biex jitlef il-signal. Mela beda bħaj signal u idum biex jitilfu. All right? Fit-T1 ma kellu signal u dam to regain it. Mela T1 dark, T2 bright. Morru fuq fett issa. Fett has a short T1. Mela, aħmar jew blu. Short T1. Aħmar, sa jilħaq iktar. Mela jekk nieħu differenza bejja u għaw on T1, kif sa jider? Hyper, ħajider bright. Hyper intense. High bright signal on T1. Għaliex? Għax laħa il-regainja iktar longitudinal magnetization from the surrounding tissue. Okay? Has a relatively long T2. Relatively long, mux twil ħafna, relatively long T2. All right? Mela ħajider hyper intense u koll. Mux too long, okay, compared to other tissues. Mela fett ħajider bright on both T1 and T2. Mela jekk għandi structure, għalhekk importanti, the basic sequences T1 weighted u T2 weighted dejjem issibhom fil-protocols. Issa jista' jkunu inversion recovery, jistgħu jkunu anka proton whatever. Imma the basics huma, mela at least from the images you already can identify between what is fat and what is water. Għax jekk għandek, jekk jiena ħadd T2 weighted image, T2 weighted sequence biss, u għandi lesion, u dik il-lesion there at bright. Can I say whether it's fat or water? On T2.
Won't be as bright as water.
It can be the same. Ma jekk jiena għandi T2 u għandi bright signal from a lesion on T2, jekk jiena l-istess lesion I do a T1 weighted sequence, jekk di baqat li bright fit T1, mela it's fat. Jekk di ġietni dark, mela it's water. This is basic differentiation from two sequences. Aħseb wara dawk is-sequences kollha. L-affarijiet kif jidru differenti on the different types of sequences. Tajjeb? Mela. Fluid is hypointense dark on T1 and hyperintense bright on T2, while fat is hyperintense on both T1 and T2. T1. What is fluid? Dark. Tajjeb. What is fat? Skin. Skin, mela fluid CSF is bright in the ventricles. The skin, fat, it appears bright on T1. Let's go on T2. Let's go on T2. Fluid is bright on T2, but so is fat. Tiġix tgħidli għax dak il-bright x'għandek ftit, dak il-bright mhux l-istess bright bħal dak, x'għandek iktar, but it's still bright. So fat is bright on both T1 and T2. Proton density, somewhere in between. Still bright, il-fat, imma water is still bright, but not as bright as T2, u mhuwiex dark as T1, it's somewhere in between. Fil-fatt, il-white u l-grey matter, you can actually distinguish between them. White matter is bright, grey matter is grey. The discrepancy between based on the amount of protons is much more evident on proton density rather than T1 or T2. Jekk tittara variations between white and grey matter. So, PD, kifetlek, jekk inti tittara ħafna drabi il-PD tintuża in conjunction with fat suppression fil-musculoskeletal. Fil-brain ma tantx tintuża, hemm sekwenzi każijiet fejn jekk inti għandek mhux il-corpus callosum li jipproduċi CSF fil-ventricles. Fakru min. Ojja, għandi lapsus bħalissa. Is-CSF fil-ventricles. Hemm xi ħadd mill-online. Le. Ujja. Min qiegħed online. Kulħadd telaq kulħadd bil-kamera mitfija.
Plexus.
Ujja. Choroid plexus. Choroid plexus. Mela, tara. Jekk inti tittara l-choroid plexus, fit-T1 ma tarax il-choroid plexus ħafna drabi, għax u obscured għandek signal. Fit-T2 għandek too much higher signal, u fil-proton density taf tarax. Veri jekk kollok jew għamil T1 u T2 għandek xi ħaġa forsi you need to query għalek tgħid ħanagħmel proton density. Tajjeb? Most likely, yeah. For musculoskeletal, l-iktar. Tajjeb? Mela, most pathological processes, such as tumors, inflammations, pathological foci, have a high water content. L-edema magħhom. Therefore increases the tissue's free water content. Mela, appear hyper-intense on T2-weighted sequences. Mela, inversion recovery sequences used to suppress fluid, such as flare. Tajjeb? Fil-fatt, T2-weighted, saying is that T1-weighted sequences show anatomy. T2-weighted sequences show pathology. Mux neċessarjament, imma dik isa għax fit-T1 jekk għandek pathological process, which probably sa jkun iktar evidenti on T2 mill T1. Jekk ħat tagħmel inversion recovery, ħat toħroġ iktar informazzjoni. Tajjeb, imma l-fatt li inti għandek bright signal from water, iċ-chances hu li sa tkun iktar evidenti on T2 mill T1. Biex qed ngħidu dejjem, ma ċ-chances hu li iktar hemm ċans li tara patoloġiji on T2, allura mbagħad you further investigate them by doing inversion recovery sequences. U hawnhekk għandna tumor in the brain, how it appears on T1. You can see there is a change there. How it appears on T2, it's much more evident. And how it appears on flare. That's the same patient, same tumor. Le, għax dawa fluid suppression. Fluid suppression. Allura, it only enhances, produces a signal from the pathological fluid. Ħabba l-inversion recovery. L-inversion recovery. Spineco da it-T2 u t-T1 it-tnejn li huma ma Spineco, wieħed T1 weighted u l-ieħor T2 weighted. Dan huwa l-inversion recovery weighted.
Il-low rate flip angle bejn 90 u lejn.
Għandek li inti twaddab il-lejti u mbagħad twaddab il-90 u lejti biex toħloq dik id-differenza bejn relaxation times li huma very close to each other. Tajjeb? M'intix qed toħloq differenza bejn water and fat, bejn water and fat għandek it-T1 u it-T2. Imma bejn water u water jew bejn fat u fat, hemmhekk għandek bżonn inversion recovery, either fat or water inversion. Jiddependi il-patoloġija x'inhi. Tajjeb? Certain tissues, such as bone, fibrous tissue, and calcification, have little or no free water. Mela dawn ma tantx għandhom hydrogen. Sewa? La m'għandhomx hydrogen, jew il-hydrogen molecules mhumiex free to spin, they're not gonna give a signal. Tajjeb? So, irrispective jekk hux T1 jew T2, they don't give a signal. So they would appear dark, hypo-intense. Tajjeb? And there you have an image of the knee, and there you have an image of the lateral knee. Mela, I have just said bone does not give a signal. Hypo-intense. What is that signal there in the bone? Is it hypo or is it hyper? The signal in the bone. Di hija l-femur, le? Aħna għedna li bone does not give a signal. If it does not give a signal, it should appear. Is it dark? Why?
Bone marrow.
Ma dak mhux il-modulon ser jiġi.
It's the bone marrow.
Yes. The signal there is not the bone. It's the bone marrow within the bone, which is fat. That is a T1 weighted sequence, therefore it's giving a bright signal. Jekk inti tara l-cortex, that black line, that's cortical bone. It's not giving a signal. Għax m'għandux bone marrow.
Tal-adma, jkun hemm daqshekk bone marrow.
Le, eżgur, mela, dak kollu bone marrow. Inti jekk taqsam għadma, tara l-Haversian system. Saħanikom dak l-spazju kollu mimli bone marrow, which is fat. Allora, it gives a signal. But the signal is coming from the fat, not the bone. Il-cortical bone is not giving a signal. Tajjeb? Issa, jekk immorru mela għandek il-cortex, which is dark, għandek il-collateral ligaments, tarom? Ligament. Naħa u oħra, which is dark. Okay? They don't give a signal. Jekk immorru fil-sagittal, għandek l-anterior cruciate. Tara this black band, dak huwa l-anterior cruciate ligament. Ligaments, no signal. Issa, kif tinduna jekk hemm xter jew le? Speċjalment jekk għandek partial tear. Għax tara signal, inti tinsix dak il-ligament hija ġol joint li għandek synovial fluid. Mela jekk il-fluid jidħollok in between the bands, ħajtik signal. Qed nitkellmu fuq line ta' ma ħanix qed nitkellmu fuq xi ħaġa kbira. Cartilage. Il-cartilage ikun iswed. Jekk ikollok tear, da triangle żgħira hawnhekk, ikollok tear li tkun messet mal-edge. Allura l-liquid seeps in, ikollok a high signal intensity surrounded by the low signal intensity. U hekk jidentifikaw jekk hemm tears jew le. Apparti li pereżempju l-anterior cruciate ligament tista' titilfu ma tarax. Għax it-setting band jekk ikun maqtuħ kompletament, dak naħa tinġibet le, naħa tinġibet law, u tara flep niżla l-isfel, flok tibqa' tila il-fuq. Jew tant ikollu edima ma tara xejn. Flip fluid, mela ċansi żur maqtuħ. X'qegħdin naraw? This is an E, l-istess. Mela fl-oħra kellna bright signal. Issa, x'għandna, ejja nibdew bis-sagittal. Yes. Għandek fluid suppression. Mela il-bright signal li konna qegħdin naraw fuq it-T1, sorry, il-bright signal li konna qegħdin naraw fuq T1 ġej mill-bone marrow, which was fat, issa it is suppressed. Ma nitkellmu din. Hawnhekk imma x'għandna? Da l-istess għandek l-adma with no signal, u hawnhekk għandek bright signal. Suppost ikun bright hemmhekk on stair? Le. Which means għandek patoloġija. Bone bruise issejjaħ, letteralment meta inti jkollok dbenġila. Fuq barra titlalek dik id-dbenġila. Jista' jkollok dbenġila in the bone. Bone bruise. Għandek hematoma collection of fluid within the bone, which is only visible on MRI. Juhu X-ray, juhu CT. Bone bruise ma tarajiex. U MRI tara. Yes? Issa sa nidħlu Pandora's box. Hemorrhage. Subacute hematoma. T1 high signal, T2 high signal. Chronic hematoma, T1 variable, T2 jista' jidher high signal. Serious blood collections, T1 very low signal, T2 very low signal. Proteinaceous fluid, T1 high, T2 high. Imma tkun tafhom, tkun taf kif jidhru biex tiddetermina x'tip ta' blood qed tara. U dak huwa xogħol? Mhux xogħli. Issa jekk inti tittoħab il-report.
Radiologist tu.
Għax inkella ma tistax inti toħroġ report u ma tkunx taf x'tip ta' blood qed tuża. U changes in the blood most likely would develop depending on how long it's been there. Għax ikun hemm changes fil-constituents tal-blood which give a different signal intensity as the blood changes. Tajjeb, kont saqsi xi ħaġa. Mhux hekk. Le, ma to come up with a differential diagnosis, you need to be familiar on how normal anatomy is presented and how abnormal anatomy, how abnormalities are presented in order to come up with a differential diagnosis. But you, based on the different types of contrast in the image, you can make quite a confident differential diagnosis compared to other imaging modalities. So it's worth the long scanning time because you're getting more information. Mela, tkellimna fuq T1, tkellimna fuq T2, tkellimna fuq proton density u kif jidru, tkellimna fuq TR and T values, and we went to some examples. We're not expecting, this is a basic course after all. All right? Tajjeb,